In this session, we will discuss how to do a simple tooth extraction and methods of incising and draining or treating a dental abscess. So what could be the possible indications of doing a dental extraction? In these situations, there are certain caveats, and those are that you cannot get a Medivac or a Dentivac. The situation is really urgent. You have a substantially good skill set, and that the extraction is a simple extraction. Essentially, the choices are very limited. The situation and the environment deems this to be a necessary procedure, and you do have a relatively good skill set and experience for this procedure. So when will you extract the tooth? If there's a severe dental decay causing severe pain, and you tried all your ways possible to control this pain and it's not working, and the last choice is an extraction, then you may think of an extraction. If the patient has got severe gum disease, his tooth is shaking, there's a loss of bone, there's a bubbling abscess around the tooth in his gums, you can then contemplate extraction. You may contemplate extraction in the case of a dental injury where the tooth is broken. The root may be left behind, but you want to take out a loose tooth to prevent the patient swallowing or inhaling this tooth fragment. Or if the patient has problems closing his mouth because of the mobility of the tooth. Another reason for extracting a tooth is a way to get drainage from a dental abscess. So if there's a dental abscess, you can incise and drain to establish drainage, and you can extract the tooth, and that will allow the abscess to drain through the tooth socket. So what are the instruments used to extract the tooth? Let us look at the forceps. Now your upper incisors have got slender roots, so the upper forceps have got slender beaks. These beaks have to be parallel to the long axis of the tooth, so that is why the upper anterior forceps are relatively straight. So in summarize it with a video, relatively straight forceps allows the beaks to be parallel to the long axis of the tooth, so you can have a good grip on the tooth. Upper posteriors unfortunately have got 3 roots. So they got 2 roots towards the cheek and 1 root towards the roof. So they have a right-sided and a left-sided forcep. And these forceps have 2 different beaks. So one of the beaks is sharp and pointed like a parrot beak, and one is a rounded beak. So the parrot beak goes onto the cheek side of the tooth because the tip of the parrot beak goes in between these 2 roots. So that is where your parrot beak goes in. The other beak is a rounded beak. The rounded beak goes onto the roof side of the tooth. As it goes onto the roof side of the tooth, because it's got 1 root and 1 slender root, and that is why the rounded end goes onto the roof side or the inside, the pointed end goes on the outside or the cheek side. That is how you hold an upper forceps. You hold it so that the concavity rests in the palm of the hand and beaks face upwards. Let us summarize this with a video, and the video is not working. Fucking hell. Let us summarize this with a video. You can see that the forceps are held in the palm of the hand, beaks are facing upwards. This is the pointy end of the beak, that's a rounded end. The pointy end goes toward the cheek side where you can see the 2 roots. The rounded end goes to the roof side. Beaks are parallel to the long axis of the tooth, and that is the upper right-sided forceps. As you can see, when we use this forceps, 1 finger goes on the outside, 1 finger goes on the inside. This is from your non-dominant hand, which is supporting the bone, and you push the forceps all the way up, as high up as you can possible. So you always support the bone when you extract the tooth and you go outside, inside, a firm grip on the tooth, established by your beaks being parallel to the long axis of the tooth. The lower forceps, lower anteriors have got slender roots. So lower anterior forceps have got slender beaks. These beaks have to be parallel to the long axis of the tooth. However, in the lowers, you have the lower lip which will interfere with the forceps. Therefore, these and all lower forceps have got these very sharp bend so that the beaks can be parallel to the long axis of the tooth without damaging the lower lip. And as you can see here, they're parallel to the long axis of the tooth, allowing you a good grip on the tooth, a good 2-point contact with the tooth, allowing you to control your forces and rotate the tooth out. You grip the tooth nice and low down as possible below the neckline of the teeth. That way you can establish a good controlled direction of force. Lower posteriors. Lower posteriors have got two roots. So lower posterior forceps have got a parrot beak on both the beaks, on one side as well as the other side, because that will allow the tip of this parrot beak to go between the two roots. And again, the beaks have to be parallel to the long axis of the tooth, and that is why these forceps have been given this very sharp angle so that you can put them in such a way that the beaks are parallel to the long axis of the tooth without damaging the lower lip. And here we see them being placed in. Again, we support the bone, one finger on the outside, one finger on the inside. The rest of the fingers are along the lower border of the mandible. The beaks are parallel to the tooth, allowing your controlled direction of force on the tooth, and you grip the tooth as low down as possible so as to have a good 2-point contact with the beaks of the forceps onto the tooth. Elevators. Elevators are essentially flattened screwdrivers which are meant to shake the tooth so that then you can take them out using your forceps. They have a concave bit at one end and a convex bit on the other side. So this is the convex side and this is the concave side. The concave side goes against the tooth which you want to take out. So before you do anything, you have to support the jaw when you extract the tooth. So in the lowers, how you do it is one finger goes on the tongue side of the tooth, one finger goes under the cheek side of the tooth, the thumb goes along the lower border of the mandible, thereby you support the jaw as you extract the tooth. So you can see here one of the special ops force medics supporting one finger on the outside, one finger on the inside, rest of the fingers along the lower border of the mandible. So let us look at principles and techniques of tooth extraction. So we are going to be extracting the tooth marked with a red arrow here. First thing is to support the jaw. So one finger is going on the inside, one finger is going on the outside, and the thumb is going along the lower border of the mandible. We take our elevator. Our elevator is placed in such a way so that the concave side hugs the tooth which you want to take out. So this is the tooth we want to take out. This concave side is in constant contact with the white of the tooth. So it does not wander away from the white of the tooth. It always remains in contact with the white of the tooth. Then you push it in gently. As you push it in at an angle of 45 degrees. You push it in with the teeth, with the tip of the elevator in constant contact with the tooth. After pushing it in, you turn the handle a quarter turn in the clockwise direction. As you turn the handle in a quarter turn in a clockwise direction, the tip of the elevator turns a quarter turn in a clockwise direction. As the tip of the elevator turns a quarter turn in a clockwise direction, it pushes a hard tooth against a soft bone, increasing the size of the socket around the tooth, loosening the tooth. Once you've done that in the front portion of the tooth, you then do the same thing in the back portion of the tooth. So you take your elevator, you push it into the back portion of the tooth, and then you turn it by a quarter turn in the anti-clockwise direction. As you turn it quarter turn in the anti-clockwise direction, the tip of the elevator turns a quarter turn in the anti-clockwise direction, pushing the hard tooth against the soft bone, increasing the size of the socket around the tooth. And thereby you are loosening the tooth in its socket. You are not levering it out. So that is how you hold the elevator. When we take our elevator, it goes in front part of the tooth at an angle of 45 degrees, and then you give a quarter turn in a clockwise direction, loosening the tooth, and then we take it on the back of the tooth, again hugging the tip of the tooth, concavity faces the tooth, it's pushed in at an angle of 45 degrees, and again you turn it as a quarter turn in the anti-clockwise direction, loosening the tooth in its socket. So that is how you loosen the tooth. Next, we take our forceps. We take a lower anterior forceps and we place the forceps around the tooth. Now the first direction of the forceps is actually downwards. We push the forceps as low down as possible, again gripping the tooth. It doesn't wander away from the surface of the tooth. So the tips of the forceps are constantly gripping the tooth. So they do not go under the gums or the bone, they grip the tooth. So as you push downwards, you grip the tooth as low down as possible, expanding the crestal bone here and shifting your center of rotation as low down as possible. Because if you don't do that, and if your center of rotation and if you grip the tooth very high, your center of rotation is very high and the pressure on the apex of the root is more, and that causes the fracture of the tooth root. So therefore you have to push it and hold it as low down as possible. So you have to shift your center of the rotation as low down as possible, decreasing the force on the root of the tooth. And then it all depends on the wrist. As you tilt your wrist towards the cheek side, you are compressing the crestal bone on the cheek side, apical bone on the root side. Then you tilt it onto the tongue side and you're compressing the crestal bone on the tongue side, apical bone on the cheek side, and it is essentially like taking a tent peg from the ground with the outside inside rotary movement, and out pops the tooth. So when we see that done in real life, we are putting our elevator here and the elevator is going in the front part of the tooth, concave side faces the tooth, turn it by a quarter turn, pushing the hard tooth against a soft bone, expanding the socket around the tooth. So it's loosening the tooth up. And once you loosen the tooth up, so remember the elevator is in constant contact with the tooth. It is not jammed between the two teeth. It is jammed between the tooth and the bone, with the tooth elevator constant contact with the tooth. And then you hold your forceps and you move your forceps, grip it as low down as possible, outside, inside rotary movement, and out pops the tooth. If a tooth is broken, again we are pushing our elevator. It is not jammed between the two roots, it's between the tooth and the bone, with the tip of the elevator in constant contact with the tooth. And then we work it around the tooth like a lever. So we are working it and we are wedging it in, and the wedge compresses the bone around the tooth so that the tooth socket is now bigger and wider. We take our forceps, the tip of the forceps goes nice and deep, gives a solid grip on the tooth, 2-point contact, and then we can rotate the tooth out of the socket. So therefore, we have been asked often, can we attempt our extraction with pliers or Leathermans? Our opinion is extraction forceps have been devised and designed in a specific way so that the beaks are parallel to the long axis of the tooth and they are concave, giving a 2-point contact with the tooth. So we do not advise you to do that. Under rare circumstances, when the situation is critical, you cannot get a DentiVac, and it is a front tooth, a single rooted mobile tooth, you may then consider using anything alternate to a dental extraction forceps to try to take the tooth out. As long as you have a good skill set, it's a front tooth which is mobile, single rooted, simple extraction. What are the possible post-extraction complications and instructions what you would give? It's very important for the patient to eat before the extraction, to not come on an empty stomach. After the extraction, it is not necessary to suture the socket. We suture the socket only if there's continuous bleeding after the extraction. You tell the patient to bite on a gauze piece for at least 1 hour after the extraction to avoid eating anything hot and hard. It's just soft and cold food for up to an hour. Then we suggest gentle, warm, saline rinses, and we'd suggest this after 24 hours. So 1 teaspoon of salt into a cup of water, the temperature of tea. After 24 hours, the patient can then rinse with it. So for the first 24 hours, stay on soft cold food. Next, no vigorous rinsing, no vigorous sucking to avoid negative pressure for at least 48 hours. So avoid negative pressure for 48 hours and avoid smoking permanently if you can for at least for a week. What are the likely post-extraction complications? If a tooth fractures when you're going to take it out, let the root remain. Do not try to dig out the root because you would cause more damage than good. Again, because it requires a separate skill set, separate instruments to surgically remove a fractured root. What if there's a post-extraction bleeding? The importance of this is to avoid post-extraction bleeding by giving good, proper post-extraction instructions. However, if a bleeding does occur, suggest the patient bite on a gauze, tissue, tampon, or a moistened tea bag folded in half and bite on it for at least 30 to 60 minutes. The tannic acid in the tea will help in the blood clot to form. If the bleeding still doesn't stop, then you can use a suture to stabilize the blood clot and decrease the bleeding. So the suture is not put to close the extraction hole. What it does, it pulls the gums across the bone to reduce the bleeding, and the suture itself helps in stabilizing the blood clot. Post-extraction infection or post-extraction dry socket. What happens is when a tooth is extracted, if the socket which forms is unhealthy, or blood clot which forms is unhealthy, this blood clot can disintegrate after 2 to 4 days, in which case there is an exposed necrotic bone and the patient gets a lot of pain. This is very common to happen in women, lower teeth, and teeth with chronic infection. Particularly if you think of a mobile tooth, a lower mobile tooth, that area has chronic infection, chronic unhealthy granulation tissue, and predisposes it to form a dry socket. How do we treat it? Generally there is a preparation known as alvogel, which is made of iodoform, and that you put it in and helps in granulation tissue from forming, covering that area, giving it protection and analgesic properties. If you don't have it, which is likely because that's rarely present in an expedition dental kit, you can use a gauze with a little damp it with a little bit of clove oil and some corsedal gel, lightly pack it into the socket and change it every 24 hours. The patient may need antibiotics. He'll definitely need some painkillers. Now the trick with clove oil is it can burn the soft tissues. So therefore it should not be dripping with clove oil. It should just be damp, and try to make sure it doesn't contact the gums. When you push it in, it should not overlap the gums around the extraction socket because it will burn the gingiva around. What if you have fully evident post-extraction infection with pus discharge? Gently irrigated with warm saline once a day, corsedal gel, mouthwash twice a day for 10 days, antibiotics and analgesics. And this same gentle irrigation with warm saline applies even to dry sockets. Before you put this dressing in, it's a good idea to irrigate that area gently with warm saline to clear out all the debris before putting your dressing inside. If you do put an alvogel dressing in, that can remain in the socket for a much greater period of time and does not have to be changed every 24 hours. It is only a locally made one which is made of gauze, clove oil, corsedal gel. That one you will have to change every 24 hours. Spread of untreated infection, incision and drainage of dental abscesses. Now, as I said, as a tooth gets infected, there's acids and gases from the dead pulp. These acids and gases leak out from the root and go into the bone. From the bone, they have to go somewhere and they develop into an untreated infection. So what about the top teeth? In the top incisors, infection can spread below the muscle attachment to the lip side or to the roof side. If it happens in either of these ways, you will get an abscess. This is a palatal abscess. How will you treat that? If you have the skill set, you would extract this root and there will be drainage through the socket. Of course, this will be a tricky extraction to do. You might then consider a wide bore needle, push the needle into this palatal swelling, suck out the pus contents, and then take a big wad of gauze. Tell the patient to bite on it for 30 to 40 minutes to prevent the dead space hematoma from forming in this area. Otherwise, you can incise and drain this palatal abscess. If you want to incise and drain this palatal abscess, the incision is done on the tooth half of the swelling. So it is done within 3 to 5 millimeters of the tooth. So if there's an abscess here, you do it 3 to 5 millimeters from this tooth. If there's an abscess here, 3 to 5 millimeters from this tooth. It's done towards the tooth half of the swelling, except in the midline. Now in the midline, we have a lump behind our upper anterior teeth, and that is the nasopalatine blood vessels, or the nasopalatine papilla containing the nasopalatine blood vessels. So we do not want to incise here. So in this area, we do not cut 3 to 5 millimeters from the gum margin. But here, all the incision is done 3 to 5 millimeters from the gum margin, but not in the midline because we do not want to cut these nasopalatine blood vessels. So you can see palatal abscess, and we are going to do an incision and drainage of the palatal abscess, allowing the pus to come out from that area, like so. What happens if the infection goes above the muscle attachment into the facial spaces? You get a buccal abscess. In this case, you might get a swelling around the eye. This swelling around the eye is not because of collection of pus, it is because of the blockage of the lymphatic drainage. And that is quite a common appearance. How do we do this? We incise and drain. It's very important that when you're doing an incision and drainage, you go all the way down to the bone, because this is the tooth where the pus is coming from. Maximum collection of pus is next to the bone. So put your closed tweezer inside and open up gradually by blunt dissection, going all the way down to the bone where the maximum amount of pus is collected in that area. So it's important to reach subperiosteal region because that is where there is the maximum collection of pus. What about the posteriors? The pus could go above the muscle attachment to the cheek side, resulting into a buccal abscess. Again, if we want to drain this abscess, we do an incision in the tooth half of the swelling. So 3 to 5 millimeters from the gum margin, we make an incision. When we do an incision in the tooth half of the swelling, 3 to 5 millimeters from the gum margin, we take our knife and we cut it anteriorly. So we do not take our knife and go posteriorly, we take our knife and go anteriorly. The reason is if it slips as it's going anteriorly, it's okay. If you're doing the incision posteriorly and if it slips, it might go into the cheek mucosa where there are some fairly big blood vessels there. So therefore, this is the buccal abscess in the posterior teeth. So first we just drain the abscess, and then we got to increase the length of the abscess and go all the way down to the bone. So therefore, you will notice that the knife being turned around, the blade faces anteriorly, and as it is put in, the incision goes from back to front and not from front to back. So you're putting your blade in and the incision is going from back to front, allowing you to go all the way down to the bone where the maximum amount of pus is collected with these teeth. So getting all the pus out from that tooth. What happens if the infection goes above the muscle attachment to the tongue side? You do not want to incise and drain there because there's a big blood vessels in that area. However, if you can extract the tooth, if the tooth is very loose, mobile, if you extract the tooth, by extracting the tooth, you will get enough drainage from the extraction socket, and that would relieve the pressure in that area. Ludwig's angina is a swelling which is more a cellulitis rather than an abscess. The swelling goes below the lower jaw and below your tongue, causing the tongue to protrude upwards and outwards, and there's a swelling crossing the midline below the lower jaw. And this is a Medivac situation. This is the only critical factor in dental causes, and it can be life-threatening. We do not advise intubation for these patients because there could be a parapharyngeal abscess and it will be a very difficult intubation. You suggest high-dose antibiotics, Medivac the patient, keep the patient under close observation. Especially with children, the patient can rapidly deteriorate. So you can see the swelling crossing the midline below the lower border of the mandible, and once we check in the mouth, you will see that there is a swelling below the tongue also crossing the midline, and it can push the tongue upwards and outwards. Now, especially in children, patients can deteriorate very rapidly, and you can develop stridor, and they require urgent attention and constant observation, as you can see here. So especially in refugee camps, local patients or patients who are immunocompromised, this can rapidly spread, and it is a very difficult case to manage, and you need a high dose of antibiotics. If you do locate a very loose mobile tooth, which you can take out and establish drainage from the loose mobile tooth of the local pus collection, that will definitely help. Do we place drains after doing incision and drainage? We try to keep things as simple as possible on expeditions. So we rarely put a drain in. However, if the situation arises, you can take the finger end of a glove, snip the front end of it off so it becomes a tubular piece of plastic, place it into the place where you've incised and drained, and suture the ends across, and then Medivac the patient. Antibiotics commonly used in expedition dentistry the infections are very often caused by anaerobic bacteria. There's a contribution by aerobic also, but it's essentially a combination infection of anaerobic and aerobic. It's very rarely caused only by aerobic bacteria. So therefore, if you're not allergic to penicillin, augmentin is a good antibiotic to give. If you don't have it, you combine amoxicillin and metronidazole. If you're allergic to penicillin, clindamycin is a good choice. If you don't have clindamycin, then it's a combination of metronidazole with erythromycin, clarithromycin, or azithromycin. It's the next choice for you. Anti-inflammatories are essentially ibuprofen, diclofenac, and as usual, you can add paracetamol to ibuprofen to get your better analgesic effect. You can increase your dosage of ibuprofen from up to 800 milligrams 3 times a day, and a maximum dose of 3.2 grams a day. The only note of caution is in ultra or extreme athletes, and even in expedition participants who are dehydrated, worn out. These people are very prone to rhabdomyolysis. There's a breakdown of muscle tissue. Muscle fibers contents enter the blood, which is harmful to the kidney, causing kidney damage. So in these patients, to add ibuprofen to the mix increases the danger of kidney damage. So therefore, you might consider to avoid it for these patients. Thank you.